be online. It will be a virtual talk, but we can discuss with her and we can communicate with her. Just I'd like to introduce Dr. Hiba Aisawi. Dr. Hiba Aisawi is a clinical professor of psychiatry in Ain Shams University Hospital, Cairo. She has been a medical director for eating disorder clinic since 2013 at the Institute of Psychiatry. She has practiced since 28 years, writing, lecturing, supervising, directing an outpatient eating disorder clinic. Her role is expanded treatment service to include pediatric, adolescents, adult, geriatric population. Hiba is passionate about empowering, educating parents as well as children. She is consultant to Oasis International School, American University in Cairo, National Council for Childhood and Motherhood. She maintains a private practice in psychotherapy and medication management in Cairo. Hiba has presented extensively nationally and international conferences as well as provide campus-wide training. She has published in academic journal and popular media, as well as contributing chapter to several books, and appeared on a variety of local and national news and radio outlet. Hiba is the founder, president of the Egyptian Association of Eating Disorder. So today, our subject will be eating disorder. I don't know if it is common here, it's a problem here in our culture or not. I'm not very aware of that. But let us hear what Dr. Hiba will tell us. Dr. Hiba.
Hello, مساء الخير.
Yes, we can hear you.
Okay, fine. Sorry for the delay. Sorry. First, I want to express my many thanks for Dr. Medhat Sabahi to invite me to be with you today. As well, I thank you, Dr. Talat, for this nice and brief introduction. I'm so happy to present one of my subspecialty in psychiatry, the eating disorder domains. I have been working in this domain after my MD since 2013 till now. And I believe that the area of eating disorder is quite growing as regard the clinical and our experiences about treating the patient and the clients of eating disorder. My topic today is the comorbidity of eating disorder. I guess that when we are in our practice, private practice, we are always seeing cases of eating disorder. And nowadays, it's not so difficult to diagnose a case of anorexia nervosa or bulimia nervosa or binge eating disorder. Definitely, some of the patients, when they came to the clinic, they told me, yes, doctor, I'm suffering from anorexia nervosa. And I went, I saw Dr. XYZ before, and my case is still the same. I have, and still I'm suffering from anorexia nervosa. Here it comes the problem. Why the results worldwide of treating anorexia nervosa or bulimia or any type of feeding or eating disorders is always unsatisfactory. So we have to look around this to know more. Maybe there is a comorbid psychiatric disorder hand in hand with the eating disorder, which always hinder the proper diagnosis and the proper treatment. Here is our topic today. As you know, eating disorder and feeding disorder is one of the devastating disorders. And here I want to tell you that after the introduction of the DSM-5 in 2013, we have a very promising diagnostic tool, because it is very clear and comprehensive about the new diagnosis of eating disorder after the introduction of RFID and the specification of anorexia nervosa. So we can tell that really eating disorder is one of the devastating disorders. The psychiatric comorbidity with an eating disorder, it's not important for clinical diagnosis. No, it becomes so important in our future research in the Middle East. Why we are so interested in clarifying that relationship? Because diagnosing and treating these comorbidities definitely will improve the outcome for the eating disorder, and on the other hand, the eating disorder will significantly improve the mental condition. So it's a bidirectional. It's a bidirectional relationship between eating disorder and psychiatric comorbidities or mental disorders. We want to clarify. We want to clarify this bi-directional relationship. Why we want to clarify? To have a proper diagnosis and, as you know, a proper and satisfactory treatment. To clarify this relationship, we have to know in precisely 2 points. First point is to know the timelines and the sequencing. What I mean that who's going to start first? A mental problem or eating disorder, or eating disorder then followed by the mental problem? Here, what I meant by the sequencing of the psychiatric comorbidity in eating disorder. And second, I want to clarify more the potential impact of these comorbidities on either diagnosis or the treatment plan and the prognosis of eating disorder. To know this, here is my roadmap. I want to identify first the most common comorbid psychiatric disorder with eating disorder, and we want to highlight the confounding factor between the diagnosis and the adverse effect of these effects, this confounding effect on the diagnosis and on the treatment. At the end, we're going to discuss the pharmacological treatments recommended to be used with the eating disorder and other comorbid mental disorders. To start with the identification of the most common mental disorders with the eating disorder, we want to start with that the comorbid psychiatric disorder with the eating disorder is so prevalent. Almost 97 of the female of inpatient with eating disorder was found that they have one or more comorbid disorder. So this is it's a very high statistics. And about 70% of individual with anorexia nervosa, they met the criteria for another psychiatric disorder. Not only anorexia nervosa, but 88 of clients with bulimia nervosa, they met as well the diagnosis of other mental disorders. Anorexia nervosa and binge eating disorder, which reach about 65% of patients suffering for binge eating disorder, they reported a prevalence of major depressive disorder. So as you see that we have plenty statistics and very high statistics to highlight the comorbidity with the mental and the eating disorder. What are the most frequent comorbid psychiatric disorder hand in hand with the eating disorder? On top of our list is major depressive disorder, and then we look for the suicidality, and then the borderline, anxiety and OCD, substance use disorder, and post-traumatic stress disorder. But here I want to tell you that this is not the only mental disorder which are always comorbid with the eating disorder. But I choose the most frequent comorbid disorder to discuss it today. I want to start with the relationship with eating disorder and depressive disorder. The major depressive disorder is so frequent and comorbid with the psychiatric disorder. The lifetime prevalence of comorbid depression with eating disorder is so high. It might reach 94%. In anorexia nervosa, the mortality rate is 18 times higher than when there is comorbid depressive disorder. And in research done in 2021, concluded, done by LISI in 2021, they concluded that anorexia nervosa patient has greater clinical severity when they had comorbid depressive or generalized anxiety or social phobia over their lifetimes. And this is a very and important clinical point, because when we see a case of anorexia nervosa and it has these depressive symptoms or depressive disorder, we have to look carefully for these patients and manage it carefully. Regarding the diagnosis, as you know, there is always a confounding factor between depression and anorexia nervosa. This confounding factor comes from the starvation. Sometimes the starvation may confound with, which is always a main symptom in anorexia nervosa, and on the same time we might see this type of loss of appetite and the patient is not eating well in depressive disorder. So starvation may be a confounding factor in diagnosis of depression in patients and clients of anorexia nervosa. Not only the starvation, but also the empty mood and the extreme lability of mood. This might be seen in clients with anorexia and depressive clients. Also, the vegetative symptoms like an energy loss and loss of libido and the sleep disturbance and insomnia, both are these symptoms are prevalent in depression and anorexia nervosa. Cognitively, the patient will experience helplessness and hopelessness, especially when the anorexia nervosa became chronic. We can see the patient coming to our offices telling that I did everything and still I'm suffering the same. I'm always thin. Leave me alone and leave me die in peace. So always depression and anorexia nervosa have many confounding factors. To unpuzzle this confounding factor and unpuzzle this relationship between depression and eating disorder, we want to study the onset. Which comes first? Either eating disorder followed by depression, or vice versa, depression start and then eating disorder come after. Regarding the relationship between eating disorder and depression, the onset of eating disorder and depression always eating disorder tend to precede the development of depression. And this is from my clinical point of view, I do much agree about this, because when we treat like a patient with anorexia nervosa and she's almost in remission, we are always waiting for maybe for depression will come out in a couple of years. So we want to, from this point, I can tell that we have to follow meticulously the patient with eating disorder, especially anorexia and bulimia nervosa, not only for 1 or 2 years, no, for more than this, about 5 years follow up. Just we are to follow up first, and then we are always waiting for pop up of depressive symptoms or depressive disorder. I want to tell more that the comorbid depression can predict a longer course of treatment. the patients with eating disorder and comorbid depression will take much more longer time than the patient with eating disorder without depression. And another point which is so important in treating the patient, that we don't have to be, as a clinician, easily disappointed, because the depressed mood will improve not early, but with the weight restoration. There are always much correlated. The mood will not be improved unless the weight will be partially restored. The relationship after the depression, we have to look for the suicidality. The relationship between eating disorder and suicidal attempt are very prevalent. Either the passive ideation of suicide, that the patient wants to get rid of his life, and the non-suicidal self-injuries, like self-harm and cutting, burning, scratching, or harming the skin. There are these two subtypes are so prevalent in clients with eating disorder. And clients or individuals with any type of eating disorder history were more prone to have a greater number of suicide attempts compared to those without eating disorder. And here it comes another point which is clinically so important. We have to put on in our sheet asking for for eating disorder, the specialized sheet for eating disorder. We have to put a good and a good question about the suicidal ideation. And we're not going to be astonished that we are going to find many patients with eating disorder, either anorexia or bulimia, or even binge eating, suffering from this, and this idea is running in their heads. A lifetime prevalence, a lifetime history of eating disorder are increased always with the suicidal ideation, the risk of suicidal ideation and suicidal attempt history. The prevalence of suicide attempt in a study, in a meta study, were done on 36,000 clients with eating disorder history, was about 25% among those who have a history of anorexia. So we can tell that the suicidal ideation is so prevalent in patients with anorexia nervosa. And the prevalence of suicidal attempt, especially in the subtype of binge purging in anorexia nervosa, was much higher than that of restricting subtype in anorexia nervosa. So we can add that the subtype of binge purging anorexia nervosa is much more. These clients are much more suffering from suicidal attempt. So we have asked about this in our history taking, because if you miss it, we're going to miss an important portion of the case. And the prevalence of suicidal attempt in the bulimic patient, it's about 31.4%. Not only anorexia nervosa and the bulimia, but the patient with binge eating disorder, about 23% of this patient with binge eating disorder, they had an attempt suicide. As you see, it's so prevalent. It's so prevalent, the suicidal attempt in the population or the clients with eating disorder, either anorexia nervosa, bulimia, or binge eating disorders. What are the risks if we want to suspect these patients with suicidal ideation? We have to look for the risk factor. I'm going to ask about the suicidal in details. Definitely clients with anorexia nervosa or bulimia or any type of eating disorder and depression, or the clients with previous suicidal attempt, or people who are always preoccupied with death. And also we have to look for the patient who's always talking about how to kill themselves. Warning statement. There is a warning statement we might hear from our patient that I wish that I were dead, or I'm a troublemaker for you, my parents, so you are better without me. I wish I go to sleep. I never wake up. I just can't take it anymore. These are warning statements. We don't have to mix these statements, because there are these statements coming from the head of the patient. There are a high risk for suicidal ideation, even if they didn't do any attempt, but we have to look for this very carefully. It's so serious. After discussing the depression and suicidality, we have to look for the personality disorder and its comorbidity with the eating disorder. On top of the personality disorders, which is so prevalent in eating disorder, it's a borderline personality disorder. People with a borderline personality disorder have a greater prevalence of eating disorder than people in the general population. And the psychiatrists and the psychologists who's working with the clients with an eating disorder are always facing this issue. The borderline personality are much so correlated and prevalent in eating disorder and eating disorder and borderline, so prevalent, too much attached. 53% of the patient with borderline personality disorder met the criteria of one of the eating disorder, compared to 24% of patients with other personality disorder. So we can tell that the borderline personality disorder is so prevalent in patients with eating disorder. So we have to look for the personality disorder. We can do schedule to diagnose the personality disorder hand in hand with our sheet to diagnose other psychiatric disorder. 21% of patients with borderline personality disorder met the criteria for anorexia nervosa, and 24% of patients with borderline personality disorder met the diagnosis for bulimia nervosa. So the comorbidity with borderline and eating disorder, either anorexia or bulimia, is so prevalent, so we have to look for it very carefully. After this, we go to the eating disorder. Is it prevalent, or is it correlated with the eating disorder? Yes. It's an anxiety disorder co-occur in more than half of patients with eating disorder. About 56% of patients with eating disorder that are suffering from an anxiety disorder. Not only anxiety disorder, but as well rituals, which are so
Doctora,
in the morning and in the afternoon.
Wrong
and
with
this
your internet connection, please. If somebody is using phone or internet in your place, please let him to shut down.
Okay. Here is better?
Yes. Okay.
Okay?
Yes.
Okay. About about the OCD, about OCD rituals, I can tell that there is a compounding factor between OCD rituals and anorectic patients. There is some rituals which is always common in the OCD patient and as well in the anorexia nervosa, like waiting themselves every day in the morning and in the afternoon, and doing some heavily exercising themselves too much. This we're going to discuss in few minutes. Not only OCD and generalized anxiety, social phobia is prevalent in 20% of cases of anorexia nervosa. Panic disorders affect 11% of eating disorder cases, and the generalized anxiety is prevalent in 10% of eating disorder patients. So anxiety disorders and OCD related disorders are so common with eating disorder. So we have to look for this as well so carefully. The ritualistic activities I've just mentioned right now, like excessive exercising and repetitive weighting ourselves, are confounding factors. Perfectionistic as well, perfectionistic attitude between. Sorry. Perfectionistic. Sorry for this. I didn't do the full screen. Perfectionistic is a major trait for patients with anorexia nervosa, and this is a character trait which persists even after weight restoration. As you know, it's a confounding factor between patients with anorexia nervosa and OCD clients. We come to the OCD personality disorder, PD. These are a population which are always preoccupied with rules, orders, and control. This is quite different from the OCD patient, because, as you know, OCPD are not believing that this idea inside their mind are an inclusive ideas, the diagnosis of OCD. They believe this is normal, and no one, that are so rigid, and no one can modify this rules and control about my life. So the patient, this is very prevalent patient with OCPD and eating disorder, and sometimes there are mistaken as an OCD. So we have, when we look for a case of eating disorder and OCD, we have to do the clinical examination very well, because there is always a confounding factor between OCD patient and OCPD, which this population of clients which are always attached to rules and order and control, and as well they are very, very, very stubborn. If we look to the onset and the relationship between anorexia nervosa or eating disorder and an anxiety disorder, what comes first, anxiety or eating disorder? Here we have to put it clearly in our mind. An anxiety disorder always come first and precede eating disorder. And this is as well from the clinical point of view. When we see a child or an adolescent suffering from anorexia nervosa, from an anxiety disorder, we have to give some tips to the parents that the child must be monitored and carefully for their meal and eating habits and eating behavior, because the possibility of raising the diagnosis of disorder, either anorexia or bulimia, is very high. It's very high, and the child and adolescent may develop later in their life after the anxiety attack one of the eating disorder. And there is some researcher who's always explaining this theory as the eating disorder becoming an unhealthy coping mechanism against the childhood anxiety disorder. And this will alleviate a bit the anxiety disorder, but as an unhealthy coping mechanism, the client will be suffering from eating disorder, either anorexia and bulimia, and maybe later in life they are going to suffer from a binge eating disorder. So early onset of anxiety disorder may present a genetically based pathway toward the development of eating disorder. Here we come to another point of clinical sense. We have to put it in our mind that we have to ask about the family history. As you know, as all psychiatric disorder, we have the genetic vulnerability and as well the genetic vulnerability for eating disorder, which is always running in families. We have to put it in consideration, especially in child and adolescent clients with anxiety disorders. As we discuss about the most frequent comorbid, we have to shed some lights on the post-traumatic stress disorders and its relationship with eating disorder. Post-traumatic is common with eating disorder. It's about 13% in patients with eating disorder, and post-traumatic is presents 50% of the clients with restricting form of anorexia nervosa, and 80% in the clients with anorexia nervosa binge purging subtype. And the severity of post-traumatic stress disorder tend to increase with severity of eating disorder. So we have to look for the post-traumatic stress disorder in all cases with eating disorder, because not to miss one of these mental or psychiatric diagnoses. At the end, I want to shed some lights on the relationship between substance use disorder and clients with eating disorder. So it's about 25% the substance use in clients with eating disorder, and the time life prevalence is about 46% in bulimia nervosa. And as we know, you heard about this new diagnosis, but it's not written or mentioned in the DSM-5 or ICD-11, the drunkorexia. This population of clients are always using the anorexia nervosa the alcohol consumption, the alcohol consumption as a suppressor of appetite. They are always drinking and using this alcohol as suppressor for appetite. Some clients also, they may use alcohol as self-medicating to alleviate the anxiety, which sometimes underlies the disordered eating, not the eating disorder. Coming to the third point in our roadmap is the discussing the different pharmacological approach for treatment of these comorbid. And this is an important point because when treating cases with eating disorders, we are in a mess because regarding the NICE guidelines, we don't have a definite like an antidepressant or an anxiolytic medicine much used in the NICE, much used or well approved in the NICE guidelines. So we have to mention now that in treating the eating disorder clients with depression, we can use, by the guidelines, we can use any antidepressant, either SSRIs or SNRIs, or except the tricyclic and the monoamine oxidase inhibitors, there has to be carefully weighted against the side effect of these antidepressants. So we can tell that all antidepressants are used except the tricyclic and monoamine oxidase inhibitor, which are not so advisable to use it in treating depression in clients with eating disorder. What are the dosages? What are the dosage needed to treat the depression in clients with eating disorder? Fluoxetine and paroxetine and citalopram should be started with the 20 milligrams, and sertraline started with 100 milligram, venlafaxine at 75 milligram per day. And this is, as you know, the usual dosage used. But it's not. Also, I want to clarify that it's not necessary to reduce the dosage according to the patient weight. So we can start with the usual loading dose with antidepressant in treating these patients. But we have to be so careful with treating the patient with very low weight. I mean, the patient with anorexia nervosa extreme type. So we have to reduce the dosage of antidepressant and increase it bit by bit by the restoration or partial restoration of weight. It's very important to provide the adequate dose of the antidepressant to have the desired effect and to alleviate the depressive symptoms. I want to make it clear that the antidepressant is not having much effect on the anorexic symptomatology. It's not. It's antidepressant. It's not an anti-anorexic drug. Antidepressant is used only if there is a comorbid depression in cases of anorexia nervosa. And patients with anorexia nervosa will not fully respond to antidepressant until the weight is restored. In treating the patient with binge eating disorder and depressive symptoms, so we have to look for the CBT and interpersonal therapy. And when it comes to the pharmacological treatment, we can use topiramate and or naltrexone for binging, and for appetite regulation, sibutramine, and for obsessive thoughts, less amphetamines, and for anxiety and depression with binge eating, we can use SSRIs, SNRIs, and vortioxetine, the new Brintellix medication. And what we're going to use as a medical treatment for patients with an eating disorder and suicidality, as usual, when we have a patient with suicidal ideation, this client has to be hospitalized, because we have to increase the security for the patient. Short-term treatment for this crisis and monitoring the social support and removal of the lethal method and treating the acute psychiatric symptomatology, that are the first line to treat any client or any patient with suicidal ideation. Here, the dialectic behavioral therapy is a target. It's a target, and it's a good tool to use it with the patient with suicide and eating disorder, because suicidal behavior will be considered at the highest priority for treatment using the DBT technique. In treating the patient with OCD and eating disorder, there is little responses on OCD using pharmacotherapy or psychotherapy until changes has become to occur in the symptoms of eating disorder. So we're going to treat the eating disorder with the regular or the known lines of treatment, and then we look after the responses after of OCD. So we don't have to be worried about this because it will take more time to respond. Once changes has started, treatment with antidepressant used in OCD will take place and will be so effective. Start with typical dose of antidepressant like fluoxetine, fluoxetine or paroxetine or citalopram 20%. And here we don't have to reduce the dose on account of the patient. Whatever is the weight of the patient, so we don't have to reduce it. And definitely, as you know, OCD patient will use more than this dosage to have the proper or the desired responses. As if we have the decision to make or to increase the dosage of antidepressant, it should be raised to the highest dosage that the patient can tolerate. And a small dose of antipsychotics used as an augmentation will be so effective. So a small dose of risperidone will be so effective in treating the patient with OCD and eating disorder. But as a clinician, I can tell that we should resist our urge to increase the dosage of antidepressant in patients whose eating is not improving. Always we are looking for rapid responses. Sometimes we go quickly and we increase the dosage so quickly to get the better responses. But here we have to be so cautious and not going so fast and so high with the dosage of antidepressants. In treating the patient with eating disorder and borderline, I can tell that the DBT, which was originally created to treat the borderline personality disorder, is used in the eating disorder and is effective as well. The three core skills important to be introduced in treating this patient with borderline is the mindfulness, relational skills, and stress tolerance, and emotional regulation. As emotional dysregulation and impulsivity are the core psychopathology in either the borderline and the eating disorder. So tackling these 4 points and core skills will be so effective in treating the eating disorder and the borderline personality clients. And this, if we are going to go and what the medical treatment used to treat borderline and eating disorder, antidepressant, venlafaxine, fluoxetine, Brintellix, sertraline, and Spravato as an antidepressant are much used and there are approved by the NICE guidelines. Antipsychotics like aripiprazole, risperidone, quetiapine, olanzapine, neopressin are also used as well. And I have to mention that neopressin is much used in patients with borderline and eating disorder, and it will carry a very good responses. Mood stabilizer like topiramate, it's well used and it has a very good and promising result. Lamotrigine and valproate are used as well. So antidepressant, antipsychotic, and mood stabilizer are the regular lines of pharmacological treatment in treating borderline and treating borderline with eating disorders. In our clients with PTSD, post-traumatic, it's not recommended at all to start with the benzodiazepine. It's better or it's approved to start with low dose of antipsychotic, not preferable to use benzodiazepine. So a typical antipsychotic, small dosage of quetiapine 3 times a day or risperidone is used instead of the benzodiazepine. And some patients may require high dose up to 200 milligram of quetiapine per day to treat the PTSD. And clinicians should always try to use the lowest possible dose, not because we don't want to let them go into side effects, and this will carry a very bad relationship between the patient and the drug used. In treating the patient with substance use disorder, here we have to treat first the substance use, and then we go and treat the eating disorder. So we have to put the patient or to advise him to be dry out in a ward or residential treatment for 30 days, and in a treatment center who's interested and experienced in treating eating disorder. So we start with treating the substance use, and then in an inpatient residential treatment, and then we look after for the eating disorder symptoms and treating the eating disorder. Pharmacological treatment used for substance use are not always well recommended. At the end, that people with comorbid mental disorders in our population with eating disorder has to be much carefully diagnosed, because this will carry a very good therapeutic and good results when we look for both either the eating disorder and its comorbid mental disorder. Using an integrative therapy will always provide the best option for long-term physical and mental health of eating disorder. Integrative therapy, this is the promising tools to treat population with either eating or mental disorder. And I can tell that we have to include a comprehensive screening for a range of all mental disorders for patients with eating disorder. So I can advise that as we do in our clinic here in Cairo, in the eating disorder clinic in Ain Shams University, we are always screening for all mental disorder using the psychiatric sheet hand in hand with the eating disorder sheet. So we have to do both to rule out the comorbid disorder and to proper diagnose the clients with an eating disorder. The first setting and the first interview with the clients with eating disorder, it will last more than 1.5 hours, because we have to do the two sheets to have the proper diagnosis.
Dr. Heba, because we are ahead of time, please, can you take some questions?
Okay, I already finished. And at the end, this is my last slide. So at the end, we have to always addressing the multiple diagnosis to ensure an efficient and long-lasting recovery for clients with eating disorder. Thank you. And sorry again for this delay.
Okay, I think people here in the workshop wants to share with you some of their thoughts and some of their inquiries. So if anybody had any question, Dr. Heba will stay with us for some time. I have a question for you in the beginning.
Okay, good.
Do you think that eating disorder is a common problem in our culture, or it is just a cultural bound syndrome? Because we here in UAE rarely see cases of anorexia nervosa, really. Sometimes we see cases of binge eating of bulimia nervosa,
Yeah.
but very rare to find somebody with anorexia nervosa, typical anorexia nervosa, and if we find, it will be coming from other place, from western side of the world. I don't know what is the situation in Egypt.
Oh, I guess because we are always screening for these clients, we have a specialized clinic for eating disorders since 2013, and we are running this clinic weekly from that time till now, and we have. I can get statistics. I can send it to you in what we did it in Egypt. Prevalence of anorexia nervosa and bulimia nervosa and in binge eating disorder in Egypt, either in Cairo or in the rural area. We did it even the prevalence of eating disorder in rural area. It's so prevalent. Because we are always looking for this, and we are always looking for this also in the adolescent period, where the eating disorder is by model at the age of 14 and the age of 18 years old. We are always assessing the eating disorder in such a population, in such age. I can tell it's always prevalent, and much prevalent in Cairo, as in USA. It's also prevalent. It's a prevalent. I don't know the figures in Emirates, but I know in Egypt it's so prevalent. I can forward for you, dear doctor, the statistics in Egypt.
There are some questions here.
Thank you,
تفضل.
Dr. Hiba, for your comprehensive talk. You mentioned as the mood stabilizer that you can use sodium valproate or valproate, although the eating disorder is more common in female, and the recent guidelines have said that to avoid using valproate with the childbearing period for female. So do you still consider valproate for eating disorder as a mood stabilizer?
Excuse me.
Yeah. I think something went wrong.
What happened?
She left? Yeah, exactly. That's what I felt. Thank you.
ايه اللي حصل؟ ها؟ We can discuss with each other until, what was your question?
Eating disorder is more common in female than male.
Yes.
And she mentioned in one of the slides that using valproate is one of the options as a mood stabilizer. Although the recent guidelines have excluded using valproate in childbearing period for female. So do you still use it with eating disorder? Is it still used in...
I will tell you something.
Yeah.
She is still online? Dr. Hiba?
Yeah, I'm in. Yeah, I'm in.
You heard the question or not?
Oh, yeah. We don't use valproate for female adolescent, or it's for older age. Older age we can use it. And as I mentioned right now, topiramate is much more used as a mood stabilizer, better than lamotrigine or sodium valproate. And if we are stuck to use it, we are going to use it in an older age, not in adolescent or childhood period.
Thank you.
Any other questions, جماعة? Or I was surprised by the great prevalence of the suicide or suicidal thoughts among the eating disorder people, especially the binge eating disorder. What is your explanation for that? The main goal of the girl who wants to reduce her weight is to be more attractive. This is the sexual competition, okay? More attractive to other than to male, but in the same side, what she want to commit suicide. Do you have an explanation for this paradox?
I believe that this is not only to be attractive, it's not the only psychopathology behind the binge eating disorder or any other eating disorder. There is many psychopathological background behind the cases. We can't tell this is the only one, but maybe it may be one of the psychopathological effect behind the cases. But what I can tell that suicide and suicidal ideation are so prevalent in cases of eating disorder. Not for the long process of eating disorder, but also for the comorbidity with eating disorder and the comorbidity of depression as well. So we can't undermiss ever the possibility of or the comorbid of depression, suicidal attempt, and eating disorder.
Thank you very much, Dr. Heba. And because there is another session now, we thank you very much and sorry for any inconvenience. And inshallah, we will see you face to face in another occasion. Thank you.
It's my pleasure. It's a pleasure to be with you. I'm sorry I can't be able to join the meeting physically, and hope to see you soon.
No problem. Thank you very much. Okay, goodbye.
انا هكون تشير وانا البريزنتر. ادكشن في الاثليتس، ادكشن في الاثليتس، في الرياضيين. طيب you can share it if you want. You can share it if you want. Can we get the light a little bit? Yes, I was about to say if you people can come to the front. So, yeah, we can start directly. Hello everyone, good afternoon. I think first I would like to thank you all for being here until the last session of the third day. I know it's a bit difficult, but thank you so much. I'm going to be chairing the session. My name is Dr. Mu'az Siddiq, and at the same time I'm going to present the first lecture. So I'll start by introducing myself. My name is Dr. Mu'az Siddiq. I'm a consultant psychiatrist in the National Rehabilitation Center. It's one of the leading facilities of addiction treatment in the UAE and in the region. I graduated from medical school at Ain Shams University in 2008 and finished my Arab board degree in 2016, and then the Royal College of Psychiatrists in 2019. I have joined the National Rehabilitation Center in 2018, and before that, I was practicing in Sheikh Khalifa Medical City Behavioral Science Pavilion. So before we start, I would like to thank Dr. Midhat al-Sabahi for bringing, and the organizing committee for bringing such prestigious conference to the region. And then I would like to thank MENA Conferences for their high quality work and always excellent organizing skills. So my topic for today is addiction in athletes. So it's just an overview. And before I start, I have two mics, so I'm not sure which one to use. I'll give you this. I'll use this. Can you hear me? Yeah. So the reason I choose this topic is that since I started psychiatry, I've been interested in sports psychiatry as a new field in general. So working in National Rehabilitation Center, I have encountered few patients who were elite athletes. They lost their performance, they lost their career because of the substance use. So I thought to join forces between the sports psychiatry and addiction and to give you just an overview about the addiction in athletes. So the first thing came to my mind when I started thinking about addiction in athletes is the most famous football player who passed away a few years ago, Diego Armando Maradona. All of you know him, of course. God rest his soul. The first thing he said about substance, that drugs were his biggest problem in life. He did not say my family, he did not say injuries, he did not say anything. It was substance use. So his main substance was cocaine, and he added on alcohol. That's why he was seen in like outbursts in TV a few times. And because of his substance use, he was suspended for 15 months in 1991. So just imagine for a second how his career would have been if substance use was not there. He's already one of the most historical football player. So imagine if substance use was not there in his career. So this is our objective for today. We're going to give you just a simple introduction to sports psychiatry in general. We will discuss the different types of addiction in athletes. We'll shed lights on substance use. Then we will talk more about doping and anti-doping in sports. And then we'll end up by talking about exercise addiction in athletes. My talk will take around 25 to 30 minutes. So sports psychiatry is a relatively new field, as I said. It started in 1980s. But the International Society for Sports Psychiatry was established in 1993. It focuses on several topics related to mental health, but in athletes, such as substance use, eating disorder, doping, ethical issues that is related to sports arena in general, psychiatric medication, and much more. So, like, imagine psychiatric medication in athletes, it needs another lecture on its own. What is the rule? Sports psychology is known for years. I think decades before sports psychiatry has started, sports psychology was there for decades. They work more into performance, to deal with anxiety and to enhance performance. But the sports psychiatry, although they can also work with coping strategies and dealing with the stress of competition and injuries, they also work with athletes, their coaches, and other members of team to diagnose and treat mental health issues. They also try to help the athletes to achieve their full potentials, both on the field and off the field. So, if you can see that, like, substance use or addiction in general is at higher risk in athletes. Beside the risk of the general population, they have added on another risk. Why is that? They go through more pressure of the competition. They are more prone to injuries. And there is availability of performance-enhancing drugs, which we'll talk about later in the presentation. What are the common types of addiction in athletes? 3 most common types are substance use, gambling, and exercise addiction. In this presentation, we'll focus on substance use and exercise addiction. Anyone who worked in addiction, I think, heard the word upper-downer pairings. Do you know what it means? Anyone who has any idea about the upper-downers bearing? We find it every day in our practice. So usually what happens is some of the patients, they started using something as a downer, and later on they want to get more energy, so they started using something to stimulate them, and the other way around. So the upper-downer stimulant, they use a stimulant stacking. They use energy drinks, excitatory amino acid, caffeine, nicotine, ephedrine, and amphetamines. Later on, just to counterattack the effect of this substance, they will start using something to inhibit them, like alcohol, cannabis, or sleeping medications such as benzodiazepine. And they ended up as a gateway to start using substance. So one of the major challenges beside the higher risk of substance use is seeking help. They are famous. Most of them find it difficult to ask for help. Seeking help means they will lose their repetition, they will lose their jobs, they will lose their competition. They will not have support and understanding from their teammates, from the coaches. So it adds more pressure on athletes with substance use or addiction problems. Of course, all of us know the substance use. Substance use is different than, substance abuse, is different than substance use disorder. So in general population, substance misuse means non-therapeutic use of a drug in a manner that is potentially harmful. They did not yet reach to tolerance, withdrawal, so it's called substance misuse. But in athletes, it adds to the potential harmful use, it's a use of prohibited substance that gives them an edge or unethical edge in the competition. For example, if someone used propranolol, it's not considered substance misuse in general population. But in athletes, it's considered as substance misuse because it gives them an extra edge in their performance. So that's the major difference between the terms. But if they develop substance use disorder, it's the same between the general population and the athletes. And of course, to diagnose it, as Diagnostic Statistical Manual said, it's just a problematic pattern of using alcohol, tobaccos, and other substances that can lead to significant impairment, and to have one of the at least two criteria in the last 12 months, which is taking the substance in larger amount than intended, wanting to cut down and unable to do so, spending a lot of time using, recovering from the substance. They will have craving, or either failing to fulfill major obligations at work or at social life. They will continue the use despite causing problematic in social interpersonal relationship. They will give up on important activities. They will use the substance, although they know that it's a physically in hazardous situations, such as using the substance while driving. Continue to use despite knowing the worsening physical and psychological problem. Develop tolerance, and eventually withdrawal. So any two of these 11 criteria is enough to diagnose substance use disorder, which is the same, as we said, between athletes and non-athletes. The causes, I focus here in, beside the general cause of substance use, the genetic loading, the developmental history, everything that goes on with the general population, they have a set of reasons that put them in higher risk, as we said, for substance use. One of the reasons that they start using is to fit in. They are young, they want to fit in the team, they want to fit in their community, in college, so they might be more prone to substance use. They want to boost self-confidence. They are under pressure. Everyone is monitoring them from their families, from their relatives, from their country, so they need to boost them self-confidence, so they might use substance as a pleasure. They might use it to escape problems if they are under pressure. And as they are prone to more injuries, they might use it to relieve pain. Why do they continue? Also, some set of reasons that put them in a higher risk is to relieve stress, as we said. They developed already psychological dependence. They had negative emotions reduction after a game, losing a game, so they started using. And it helped them with the negative emotions, so they started using more. And as we say, they developed tolerance and withdrawal. One of the most important terms that you hear a lot in the substance use or in addiction in athletes is the word PED, which is performance enhancing drugs. Performance enhancing drugs is a major issue in sports psychiatry in general or in sports in general. It's used to either involve getting bigger, stronger, faster, thinner, or to pay more attention. And of course you can imagine if you want to get bigger, you will use anabolic steroids. If you want to get stronger, you can use hormonal replacement. If you want to get faster, you might use stimulants. Thinner as well, you might use stimulants, or to pay more attention, also stimulants. So they might use different substance for different purposes according to the sport they are playing in. As we say, they are more prone to injuries throughout their lives, so they might use or even prescribed painkillers, and it will end up with iatrogenic addiction, or they might get frustrated because they lost part of their career. Like imagine a football player, professional football player, he got injured and he's suspended or he can't play for 3 months. It put them under risk of frustration, getting more anxious, depressed, so it also increases the risk of substance use. One of the studies in the National Institute of Drug Abuse and the National Football League, which is the football of the Americans, not our football. So I think they called our football soccer, and they have their own American football. A study was done on 644 former NFL players. It found that 52% they used pain medication while playing, and 63 received medication from non-medical sources. As the picture, of course, this is a picture that you see in a lot of sports. To celebrate wins or to console losses, they might use more substance, and it might be a getaway to started using drugs. Also, one of the specific reasons in athletes is career termination. Some of them, because of injuries, because of any other reasons, they might terminate their career earlier. Imagine a career of a football player. You can say he's 30 years old, he's getting old. For us, 30 years old is starting our life. So for them, imagine 32, 33, and he's retired. He doesn't have a plan. If they are not planning well, if they didn't do any investment, it puts them in a higher risk to start experiencing drugs and getting more more prone to substance use. I'm not quite sure if this slide is clear, but I'll just shed a highlight because I cannot even see it as much myself. So this is just a statistics and a study published in Substance Abuse and Rehabilitation Journal in 2014. There is no much of recent research done on athletes, but in 2014 they found that 2 to 5% of any athletes had used substance in their career. Alcohol as a first substance in the Western countries, because we don't have studies in the Middle East, alcohol were the most used. 75 to 93% used alcohol at some point. Anabolic steroids, almost between 0.7 to 6.6, depending on the sports that they are practicing. Cannabis, opiates, stimulants, so name it and they all use it with a higher rates than normal population. This is the effect, the direct effect that they might get while using. In alcohol, of course, the short effect is sedation, decreased concentration, and the coordination. On the long term, they might develop liver cirrhosis and major health problems. Anabolic steroids, of course, change all the hormonal disturbances in the body, so they might develop acne. What they want is the rapid muscle gain, but at the same time, it might cause psychological and physical problems such as irritability. They are more prone into aggression. They are more prone into developing psychosis, and we have seen like steroids-inducing mania several times during our practice. It might change the shape of a male body, such as gynecomastia and hair loss, and deepening of the voice and the facial hair in female. The cannabinoids, also the short term, as all of we know it, is the bloodshot eyes, increased appetite. On the long term, lack of motivation. And imagine lack of motivation in elite athletes. It's just damaging his career. They might develop psychosis, which is the paranoia. Opiates, the short term, as we know, the constricted pupil, sedation, also the higher risk of overdose, higher risk of using IV and getting infectious disease such as HIV, hepatitis C, and hepatitis B. Stimulants, they also have short-term or immediate effect and long-term effect. The immediate is dilated pupil, anxiety, increased heart rate and blood pressure, but on the long term, it might cause physical harm to the heart, to the liver, and to the brain. What are the prevalence? As we highlighted before, 10 to 15% may have a problem with addiction. It was also a study published in American Journal of Drug and Alcohol found that 28% of retired NFL players reporting misusing prescription painkillers during their career. But the NFL, I think it's higher rate than the others. If you see it on TV, it's all depending on physical and impact. So I think they are in higher risk of getting injuries. The use of the PEDs, which is the performance enhancing drugs, is approximately, as we say, 2 to 5%, and we will discuss it later in more details. If we talk about the management is just as general as the substance use disorder in general. We aim for prevention. God forbid, if anyone started, we need to detect them as early as possible, so early detection. And if after detection, we start the treatment, and most importantly, the aftercare plan. And the cornerstone about treating any athletes is not only working with athletes, it's working with the athletes, the coaches, the other players, and the teammates. So, how we prevent is by education. The risk of consequences, it's to reach to the athletes in early age, maybe in school, maybe in the football clubs, or any other sports. We provide them with a healthy coping mechanism. We will tell them how to deal with anxiety, how to deal with pressure. We will promote supportive culture among the coaches and the other team members. The early detection part, the most important word is WADA. WADA is the World Anti-Doping Agency. This is like as we said, like the owner of the drug testing in a sports arena. There is national drug anti-doping agencies, but they oversight all the other agencies in the world. It's random, and before any competition, they do drug testing, and the aim is to detect them as early as possible, and of course, educating about physical and behavioral indicators. What is the treatment? The same as the substance use disorder is the biopsychosocial model. Biologically, it might include detoxification or medication-assisted therapy, the psychological intervention, counseling, behavioral therapy or support groups, social interventions such as education to the family and the family therapy. Our aftercare plan, regular follow-ups, regular urine drug screening, supportive groups such as Alcohol Anonymous, Narcotic Anonymous, and recovery-oriented groups, medical monitoring for any signs of psychiatric symptoms or physical symptoms, and at the end, they need to know that they are accountable for committing into the treatment program. So, just to end the substance use, the keynotes here is the drug testing policy should be strong, clear, and enforceable. It should be supported by the national teams, by the national authorities, and the sports psychiatrist must be able to do urine drug screening without the fear of consequences to the players. And we have to remember that elite athletes are role models. So by helping them, we're helping the society to reduce the substance use in general. Anyone heard about doping? Yes. Yes. Doping بالعربي اللي هي المنشطات، استخدام المنشطات. So doping is a big thing. We don't have it as much as understanding in the Middle East as the Western region, but it refers to use of any banned substance to enhance the performance, or it's considered cheating in general and prohibited in most of the sports. It gives them extra edge, and it might cause damage more than benefit. The word itself came from a Southern African origin, and as simple as using the alcohol prior to ceremonial dance, and then it was taken to the as an international word. As we said, it has health consequences, and that's why it was banned. I think some of you might remember this famous Ben Johnson incident. It happened in 1988 in the Summer Olympics in South Korea. He made a world records of 9.79 in the sprinter. He was a Canadian sprinter. So it was a world record, and after a while he was found to have steroids, and the medal was withdrawn back from him. This incident changed anti-doping in general. A lot of protocols were put after that incident in 1988. What are the types? The most common is the anabolic steroids. It's the synthetic version of male hormonal testosterone, and they used to help athletes to build muscles, increase strength, endurance, but of course, as you all know, it has a health and psychiatry and medical consequences, and it causes more damage. The growth hormone, it's normally the naturally occurring hormones in the body, but they use it beside the naturally occurring hormones to develop as well muscle mass, improve performance, but they can increase risk of diabetes, heart disease, and other health problems. Blood doping, when I heard about it for the first time, it was new for me. Huh? They spoke about blood doping. Blood doping was, when I read about it, it was the first time to hear about it. So the idea about the blood doping is to increase the oxygen and to give an edge for the athletes. If you can see in the red circle, the estimated reduction in racing time after blood transfusion over 5 kilometers is 2 minutes. So it gives them a huge edge, like if you talk about seconds and minutes. How do they do it? It's either they transfuse someone else's blood, or they take their own blood and put it in the fridge, and just before the competition, they re-infuse it back into their body, or they use the APO, which is something to produce red blood cells. So for me, it was dangerous. Imagine someone who's doing this non-medically and for no indication. So it increases the risk of infectious disease, it causes strokes, it causes other health problems such as heart attacks. And the most common, the stimulants, it gives them improvement in their performance, and all of you know that like the side effects, and it's the most common substance used in general now. Diuretics, they use diuretics for two reasons. Some of them, they might use diuretics to lose weight. Like in boxing, I think if someone is watching boxing, it depends on the weight. So grams or 1 kg can put you from a category to another category. Yes. So they might use diuretic just before the weighting of the competition to lose weight, or if they took another substance, they might use diuretics to wash up the substance before testing. And of course, it's dangerous. It might cause dehydration and other electrolyte imbalance. Beta blocker, certain sports, they like shooting, for example, it needs steady hands. So any fine tremors can cause disqualified from the competition. So they might use it before the competition, and it gives them an extra edge of winning the competition. The nutritional supplements, of course, it includes vitamins, minerals, herbs, extracts, and metabolites. For me, I was shocked to know that even the purity, not only the athletes or the consumer doesn't know, even the manufacturer, they don't know how pure it is. So it's very dangerous. It's just playing with the chances. So, and all are purchased online and the retail stores, it's contaminated with a banned substance. So, overall, as we say, doping is a serious issue, and it's important for athletes, coach, and sports organization to promote fair player and healthy competition. That's why anti-doping was developed. Anti-doping was developed in 1990s, but initiated by the International Olympic Committee to fight against doping in sports. The World Anti-Doping Agency was founded around that time, and their headquarters is in Canada. It's like a supreme international authority, and it allows them to do testing. This is from their official website. It just says what is WADA, the World Anti-Doping Agency, what is their code, and what is doping. For them, doping is not only finding the substance. If you, for example, refused to give urine or urine sample, if you tampered with the sample, if you trafficking, complicity, so not even the player, even the coach or anyone who helped the player, it might consider doping. This is the 11 violation in details. I can share it with you later. The presence, the use, the position. And this is just the protocol, the international protocol of how to collect the sample. So it talks about the athlete selection, notification, reports, providing the sample, the volume. So everything is mentioned in this. In United Arab Emirates, they have the NADA, which is the National Anti-Doping Agency. This is their hotline. And for me also, while preparing for this lecture, I was shocked when I opened their website that they have published all the name of the players that already has violations. So they put it on the website, and the violation, where they start and where they finish. I put here the names. It's clear for me here, but I think you can see it. One of them, for example, in football, and the substance they used, for example, steroids, there is THC, some use propranolol, and when did they start the active from and active till? It's online, everyone can access it, so this is it. Any questions about doping, anti-doping? Later, I guess we'll take some questions. Last thing we're going to speak about is the exercise addiction. It's just one of the behavioral addictions. Exercise addiction is a psychological condition characterized by a compulsive need to engage in physical activity or exercise, although it might be harmful on one's health. In athletes, exercise addiction can manifest by excessive uncontrollable desire to train or to compete, which can interfere with the performance, health, and the personal relationship. Similarities between general addiction and exercise addiction: obsessional thoughts. They might develop withdrawal symptoms such as irritability and anxiety. They might continue despite injuries, neglecting other important areas in their lives, extreme form of exercise and training, and feeling guilty and anxious if they are unable to exercise. It has a lot of problems. It increases the risk of injuries. It causes chronic fatigue, burnout, depression, and anxiety. Their treatment, mainly psychological through CBT. I have to over-exercise or else I will fail. What kind of cognitive error is that? catastrophic thinking. So just working with them in CBT level might help them. You might use medication if they develop any psychiatric symptoms such as anxiety or depression. You might ask them to do some lifestyle changes, such as setting realistic goals, changing the intensity of the exercise, or finding alternative activities. Other intervention might be support group, professional guidance. So we have to know that any behavioral addiction, treatment will take time and needs commitment. So bear with the process, trust the process, and go along with it. This is my references, and this is the picture of the entrance of the National Rehabilitation Center. We'd love to visit and to see you all there. Thank you so much. If you have any questions, we'll take it later. I'll introduce my colleague. We'll go for our next speaker. Yeah. Our next speaker is Dr. Michael Awad. Dr. Michael, he graduated from Faculty of Medicine, Banha University in Egypt. He has been working as administrator in Psychiatric Department, Faculty of Medicine. Yeah. Okay. Okay. Yes. I'll continue. He finished his master's degree of neuropsychiatry and medical doctorate in psychiatry and have been working as a lecturer of psychiatry. He moved to Dubai and worked as a medical director of First Psychiatric Clinic in Dubai, and moved to Abu Dhabi, and he has been working as specialist psychiatrist in Dhafra Hospital Sahha, and then recently he joined and moved and joined us in NRC. Join me to welcome Dr. Michael Awad.
Good afternoon, everyone, my professor, my colleagues. Thank you so much, Dr. Maiz, for these kind words. I'm so glad, and I'd like to thank you, Dr. Madhat Sabahi, for these invitations. Really, it is an honor to be here. Let's talk about very interesting topics, about my favorite topics, because it is my medical doctorate thesis in Egypt. It was about internet addictions. So let's talk about internet addictions. The objectives of these topics is overview about internet addictions, diagnosis and clinical criteria, subtypes of internet addiction, assessment tools of internet addictions, prevalence and risk factors, psychiatric comorbidity with internet addictions, and treatment. According to American Society of Addiction Medicine, definition of addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristics, biological, psychological, social, and spatial manifestations. Nowadays, there is broader view to define the addictions. As Dr. Muaz said in his lecture, nowadays there is what is called behavioral addictions, and how athletes use anabolic steroids. So our direction today is to move our orientations about definition of addictions to define addiction as any activity, substance, object, behavior, even person, relationship, or way of thinking or emotions that become major focus for personal lives and a way for relief, escape, or reward and exclusion of other activity, and leads to harm to the individual or others. To simplify the definition of addictions, it is an ability to consistently abstain, B, impairment in behavior control, C, craving, D, diminished recognitions, what this means, the denial, E, emotional dysregulations. As we know, the very important traits in our patients, the emotional dysregulation, all of them repair their mood by the addictive behavior. So we can define the addictions stimuli may be substance or behavior. As we know, the substance called in DSM-5 as a substance use disorders, and recently in DSM-5, the behavior addictions is only added as a gambling disorder. All of us know of this picture is a pictures of reward circuit in the brain. It is called mesolimbic pathway. It is neurons from the ventral tegmental area of brainstem to the nucleus accumbens of the limbic system in the brain. The neurotransmitters play in this circuit is a dopamine. So dopamine is a substance for pleasure. So all of these actions act on dopamine level in the brain, like as we see the substance, the behavior like gambling or even natural high. So all of these actions act on dopamine, but in different level. If the natural actions increase dopamine by 100 to 100 units, but the substance or others addictive behavior may increase dopamine level by 1,000 or more units. But the difference in both is the continuity. So the dopamine we gained from the natural high maintain along of times. But unfortunately, the dopamine we gain from other addictive behavior or substance is short-term dopamine. So our direction now, it is a behavior addiction. So every day we can discover behavior or substance or ways will be maybe in the future be addictive. So this list of behavior may lead to addictions like gambling, sex, love, relationship, shopping. All of us tried shopping, online shopping, especially in COVID quarantines. Work, food, eating disorder, as Dr. Heba told us about the problem in food. Internet and video games disorder. Exercise, sport, dangerous or risky behavior. Every time I checked my Facebook account or TikTok videos, I found very risky behavior did by some bloggers or YouTubers to just to gain likes or viewers, numbers of viewers. So it is a type of addictive behavior. Being center of attentions or being liked. All of this behavior may be addictive behavior. So let's talk about common features between substance use disorder and the other behavior addictions. Both of them most common happens in adolescence and young adulthood. Both of them are chronic and relapsing patterns. Both of them has craving and urge, a barrier to initiating the behavior. Both of them leads to increase getting high or decrease anxiety. And also both of them cause financial and other problems in the individual's life. So what the definition of internet addiction? Internet addiction is other types of behavior addiction is excessive or poorly controlled preoccupations, urge or behavior regarding internet use and leads to impairment and distress. Dr. Young and Dr. Griffiths, who first defines internet addictions, and they are first physicians, did a lot of research about the internet addictions. Let's talk in this slide about the early indicators of internet addictions. As any addictive behavior, preoccupation with the internet or behavior being the internet the strongest source of satisfaction in personal life. Less investment in relationships with friends and with family. Feeling empty and depressed and irritable when not at the computer, suffering withdrawal symptoms, sometimes like substance withdrawal symptoms, sometimes anxiety, sometimes bouts of anger, sometimes shaking of hand because decreasing of internet spending time. Craving more and more time spending on the computer, deception regarding time spent on online, denial and lack of sleep, and negative consequences due to internet use. Signs of teenager net addiction. Actually, it is very important topics when we talk with family or parent about the internet, even with family gathering. Everyone, every mother, every father talks about, oh my God, this is very important problem. All of my kids spend a lot of times on iPad or tablets. What the dangerous in this behavior and how we control. So it is very important for all parents, for family, for teachers to be aware about the signs of teenager net addictions. It is spending excessive hours online each day, going and the preferred online opportunity every time, negative consequences in school, ignoring family and friend in favor of internet use. Sometimes becoming angry and make troubles when we withdraw him from the internet, staying very late to be online, lying about online activities, and preference of using of internet than other activities. According to Canadian Society of Addiction Medicine, there is what is called the screen time. Actually, me and I don't know what about you, I surprised from these times, but it is a study called under 2 years old. It is child to be 0 screen time. 2 to 5 years old, 1 hour per day with co-viewing. 5 to 17 years old, no more than 2 hours per day. So it is a screen time. Everyone shall be minded about that. According to DSM-5 diagnosis of internet addiction, it is defined as impulse control disorders and includes this criteria: excessive internet use, withdrawal, and tolerance and adverse consequences. Let's talk briefly about subtypes of internet addictions. There are a lot of types of internet addiction because there are a lot of activities, online activities, but we can construct them in 3 types, like excessive gaming and gambling, sexual preoccupations, and social networking addiction. Let's talk firstly about the cybersex or internet pornography addictions. Actually, I talk firstly about the types because it is the most common type of internet addictions is internet pornography and cybersex. Actually, there is a difference between internet pornography and cybersex. Cybersex, it is sharing of sexual fantasy between 2 persons or more. But internet pornography, it is just stimulations of sexual fantasy due to viewing images or videos. The internet pornography and cybersex classified in DSM-5 is one of hypersexuality disorder subtypes. And it is, as we told you, it is the most common form of internet addictions. As Egypt is a 3rd country using word sex in online searching after India and Pakistan. Maybe the explanation to increase internet pornography and cybersex addiction is isolation and fantasy and the low cost of gaining of sexual fantasy. This is a statistic about the internet pornography websites. The second type of internet addiction is internet gambling disorders. It is just all types of activities of gambling being online, like it is called online bingos. It's like numbers and just you can take a number and earn a lot of money after getting these numbers. Sport booking like horse riding, online casino, all of this is numbers increasing by years, and explain of us to how this activity is increasing and be addictive around the world. Internet gaming disorder is also very important, especially in adolescents and teenager, and it is also considered in DSM-5 as internet gaming disorder. Actually, to diagnose internet gaming disorder, we have to indicate 5 or more symptoms of this following symptoms more than 12 months. Like any behavior, addictions, preoccupations with the internet games, withdrawal symptoms, and tolerance. That means increase the time of spending time on the internet games, unsuccessful attempts to control the using of internet, loss of interest of other hobbies, and negative consequences around the family and other activities in the life. Social networking addictions, the gratifications brought from the social media, like likes, like number of viewers, like sometimes money, all of this maybe act on dopamine and reward system and lets this behavior be addictive behavior. Facebook addictions. It is maybe in the future added on DSM-5, what's called Facebook addictions. So, assessment tools of internet addictions, actually, we depend on the Dr. Kimberly Young tools. It is called Internet Addiction Test. It is Young test. It is simply a questionnaire. It is 20 questions. The answer will be maybe not applicable, rarely, occasionally, frequently, often, always, 0 to 5. These questions describe how internet use and how the time is spent on the online, and if there are withdrawal symptoms or like an anxiety when cutting off the internet, if there are negative consequences individually or other life activities or not, all of these questions. After that, if the answer from 0 to 30 points, it means the normal range. If 31 to 49, it means mild internet addictions. If from 50 to 79 points, it means moderate internet addictions. If more than 80, it means severe internet addictions. To explain why internet addiction happen, actually there are 3 different models to explain the internet addictions. Some studies said it is a type of obsessive compulsive disorder. Some studies called it is impulse control disorders, and some studies said it is as any addictions. It has bio and psycho and social spiritual factors. This picture shows how the internet use preoccupy all of my life and all of my activities. Prevalence of internet addictions, the internet addiction prevalence is 1.5% to 0.2%, and it is increasing in recent studies. This is the title of my medical doctorate thesis in Egypt since 2 years. It was psychiatric assessment of internet addiction in a sample of university students. My thesis, it was it did in 400 students from 4 different faculties, and the aim of this study, it was to determine the prevalence of internet addictions and determine the comorbidities with the comorbidities internet addictions with other psychiatric disorders. Actually, I found in my study this picture showing the prevalence of internet addiction in my sample. Like we see mild internet addictions, it was 42%, and moderate it was 31.8%, and severe internet addiction it was 3% of the student sample, and 22.5% they was normal. In my study, the male, according to gender, male was 53.2 more than the female. These pictures showed the internet pornography and cyber sex prevalence in my sample students. It was 24% of them, they reported internet pornography or cyber sex addiction. That's a high number. According to psychiatric comorbidity with internet addictions, actually it's very important to determine the psychiatric comorbidity with the internet addictions. ADHD is very common disorder founded with internet addictions. Also, a review of 20 studies correlating internet addictions and the mental disorder, they found 75 reported significant correlation with the depression, 57% with anxiety, 60% with obsessive compulsive disorder, and 66% with aggression or positive aggression or hostility. Is very important, especially in my field and in my work in natural rehabilitation center, to determine the internet addictions and comorbidity with other substance use disorders. In my study, I found more than 50% who was positive internet addictions, they was comorbid with other substance. So is very important to look comorbidity with other substances. It is the characters of personality, addictive personality. As we will talk, when we talk about the addiction, we talk about the why. As Dr. Muiz said, actually I was shocked when I heard about the blood doping. Why? What is the aim of this behavior? It is a personality. So all of us maybe try a lot of things, but who will select this behavior and be addictive? It is the addictive personality. So we have to look at the personality comorbid with this behavior. So in my study, I found a lot of comorbid personality with internet addictions. The avoidant personality, it was very high comorbid with internet addictions, and other personality disorder like obsessive and histrionic personality. Let's talk briefly about the treatment. About treatment, it is not different than others models for other behavior addictions. But we will talk about the treatment. We will talk psychological treatment and pharmacological treatment. But the difference than others types of addictions, the abstinence, it is not our target, but maybe controlling the use or what's called responsible use, it is our target. So psychological treatment, we talk about cognitive behavior therapy, and it is some behavioral therapy to control the internet using, like practice the opposite. It means that like when every day at morning I checked my Facebook or emails like at morning, we can postpone this behavior and check maybe my email after breakfast or after praying or after making some exercise. The aim of this practice to break the routine or the habits of practicing the internet. That means of practice the opposite. External stoppers, maybe it is good with early or very mild internet addictions to like make alarm or warning about to log off of internet. Setting goals, it is like scheduling the time or control the time or time management for the patient, spending more times online, like making a schedule, controlling the internet use, like maybe 20-hour schedule. It means I will make a schedule for internet use, like every day I use internet from 8 to 10, and weekend I increasing the hours. Another schedule, 10-hour schedule, use internet like 10 hours per week. This way, like to controlling the internet use, to avoid the controlling of internet on my behavior. No, I control the internet, not the internet controlling me. Abstinence, it is very good way for comorbid with other substance use, because as in our field in substance use disorders, abstinence is very important step for recovery. So abstinence, it is good way to controlling the internet use with comorbid internet addictions. Okay, all this personal inventory, support groups. Just I will talk briefly about the medications with in internet addictions. Some studies utilize extended release methylphenidate. It is a type of brain stimulant, especially with internet video game addiction. SSRI, especially internet addictions comorbid with OCD. Wilbitrin or bupropion. It is good medications for treatment of internet video games addictions, and also it's commonly used with compulsive cybersexual behavior. Naltrexone, it is commonly used for impulse control disorders, so it is useful for treatment of compulsive cybersexual behavior. Other treatment is electropuncture. As we know, acupuncture, it is Chinese medicines, and it is some studies said it is for controlling of symptoms associated with internet addiction, like anxiety and depression. And there's some advices for parents and for physicians, and thank you everyone for listening.
Thank you so much, Dr. Michael. It's a very impressive topic. I don't have a question before we open the floor. I have a comment. So my first comment is about our practice. What we see from our patients when we reach total abstinent, you ask them during the follow-up, what do you do in your daily activities? You say just playing games. So the personality traits, as you said, he shifted from substance use, he started gaming. So I think it's a high comorbid with substance use. Thank you so much. The floor is yours for any questions.
Hello? Yeah. Dr. Michael, in your last slide, you mentioned electrical acupuncture. Body electrical acupuncture or skull electrical acupuncture or ear acupuncture? Which one?
Actually, I just read it about the electroacupunctures, how it helps in the internet addictions. Most of research called about the scalp acupuncture. Yes, yeah.
Chinese.
Yes, yes.
I mean Japanese.
Yes, yes. It was a scalp. Yeah.
Okay.
Yeah.
Thank you.
Hello, and thank you so much for both of lectures regarding addiction. Extremely interesting, and yes, definitely a burning topic. I actually have a question about the sport and addiction and athletes. I used to be a professional tennis player, so I used to play Grand Slams, and unfortunately I'm one of those who injured very early in life, so I had to stop. And yes, I do understand the pain of not being able to go back to something that you live for. Thank God I finished and I become a doctor. But anyway, you'll be surprised about the blood transfer or blood doping, how they call it. In my country, I'm East European, I'm Serbian. They used to take the sport people on the mountains. So it's a natural way of getting the red blood. Yeah, exactly. So that was one of the ways. Another East European technique, which is extremely controversial, was that for gymnastics, they used to impregnate them because in the first trimester, apparently the body releases the hormones that makes them stronger. Yes. Yes. So that's one of the ways that they used to do it and get away with it. But my question is actually, you will be surprised what I know, but my question is, did you ever, what is your opinion regarding the blockade? Like not beta blockade, but a blockade to block the pain for them to finish the competition, for example, in a big competitions like Olympic Games or World, when they need to run 100 meters and they're injured. So they block the pain and they end up being injured more. Is it considered as some kind of doping or not?
So first of all, thank you so much. I got a goosebump when you say tennis player, career termination is just like directly out of the lecture. So thank you for attending. And thank you for the information about the pregnancy. I didn't know about it and I didn't read about it actually. Yes, I know that there is a lot of underground practice, but I tried to get as much as possible I can, but the presentation is short. We have to talk later on. So your question is about like blockage, yes. So basically it's one of the most common ways of treating pain, chronic pain in general. So if it's done according to medical practice and under supervision and with the medical opinion, it doesn't consider as doping. The thing is like, when I was reading about doping, we can use even the stimulants. We can use beta blockers if it's medically indicated. For example, athletes with an ADHD. So they have a waivers. So this waiver is like, they do it before taking the stimulants or doing any procedure. So I don't think it needs even waiver if it's done under medical practice and it's done under supervision by like orthopedics or someone who's specialized in pain management. Yes. 3. Okay, we'll start here and here and then go.
Okay, I have a question to both of you, colleagues. Is there any recent studies about cupping therapy and reducing addiction, any kind of addiction? Okay?
Yeah, thank you so much. Cupping, I know the look in your face, Mr. Oliver. The cupping is just an Arabic practice, and I'm not sure if it's an international practice. It's just like they collect blood, so someone can explain it. I don't know how to explain it. Traditional healing. You know this common players when you find cups in their back? Yes, tennis players that you can saw, yeah. So the thing is like in the Middle East region, we lack research in general. And to talk about research in addiction, we lack this. And to talk about addiction in internet and sports, we will lack it definitely more than 100 times. So cupping is just very specific thing. I don't think there is any research done worldwide, but we can have a look, maybe something as okay.
And the doctor was saying this is graduated from, or he took his study from Canada, and he's doing cupping, and he mentioned that there is a strong relation now between cupping and curing from addiction, or helping addiction, and it is
It might help
it is now, it is
It
implanted
might
in
help
here.
in a way that they will not use other substance that can cause addiction. So it might have like indirect cause. Last two questions.